Well, welcome everybody and happy Thursday. I'm excited to be here. We have had this planned for a while, so it's just nice that this day is finally here to be able to join with you and to learn more about family psychoeducation. Um, I am Jennifer Hodson. I'm a licensed marriage and family therapist. I have been so for about 30 years. I taught at two universities throughout my career. So I spent 24 years in higher education, where I trained master's and doctoral level therapists and researchers. Then in 2022, August, I transitioned to Health Management Associates, which is a national healthcare consulting firm. So I got to take all of the things that I did as a professor and as a clinician and work on a larger landscape. So I get to do really cool things like this with you today. So this is part of the role, but I also help organizations enhance their EBPs, augment their workforce, and then do a lot in the space of integrated care. But my heartbeat is really for family engagement. So that has been sort of the focal point of my research and my work throughout my entire career. So I'm really, really excited to join with you today. Um, as she said, we are going to have a balance of my voice and yours. It is really important. The adult brain cannot be talked at for 3 hours. Also, you all have a lot to share and learn from each other. So the breakouts and the chatter falls where you contribute through the chat are really important learning instruments for today's training. So I really encourage you to engage with them and have fun and just give yourself a brain break. I know there's that temptation to continue to multitask. If you have to, I understand. Just try to come back to center. Give yourself the privilege of being in a professional development space, which we oftentimes don't get. So I just really respect the work you do, want to support you with it. So welcome and let's get started. So why does family psychoeducation matter? So we know through research that it is actually one of the best and most effective interventions for schizophrenia. And why is that? Well, because people with schizophrenia live in context of others. And we know through research that that can either make things more difficult in the management of their episode or make it easier. We know because we tried for decades and decades to cure schizophrenia that we can't do that. But what we learned in the efforts of trying to do that years and years ago is that we've figured out that communication and family engagement are absolutely critical to management and to quality of life for everybody. So while we think education, sometimes it seems like it's less important than therapeutic intervention. I would argue it is therapeutic intervention, and it is probably one of the more important things we do as clinicians and as providers. I just had a client the other week where I sat with him, and for years he had been given labels, diagnostic labels from the DSM, but nobody ever explained to him, actually two people recently I did this with, nobody explained to them what the criteria were, why they met the criteria, listened to what they had to say about it, and then explained it to their loved ones. So I've actually had clients bring family members to the sessions or be on the phone so they can hear why it is that this person that I'm working with is engaging in some of the things they're doing and ways that they can be helpful. So psychoeducation can really open the door for more therapeutic work to happen. Um, the evidence that I have put here is just a few things, but it can reduce relapse and hospitalizations. It also can improve medication adherence. If we can understand what's going on in the environment and how to help family members understand and engage. I have seen one too many families come to an inpatient unit for the discharge meeting, and the providers have handed them a plan that just isn't going to work with their relationship to the patient, with their lifestyle, with their resources. So it's really important that that comes together and that we're able to really improve everybody's well-being, not just for the individual with schizophrenia. And despite the evidence, families are still going to feel excluded, blamed, overwhelmed, and unprepared by an experience of working, with a loved one through schizophrenia in the episode. And so it is one of those things that psychoeducation isn't just at one point in time. It's going to be throughout because they might encounter educational systems, occupational systems, um, living communities, church communities where they are now navigating people who may or may not have an understanding, and now they're having to wrestle with that and how it's affecting them as an individual. So we know this is kind of an ongoing process of bringing education into our work. So the learning objectives, I'm going to just kind of go over them generally, is we're going to just talk about different methods that you may already have some. So we'll maybe talk about others and how we engage family members of our clients and our patients who have serious and persistent mental illness, particularly schizophrenia. But we can use this for lots of the different mental illnesses that we might be working with. The patients that I was talking about earlier both have bipolar 1 disorder. So I was doing a lot of psychoeducation around that. Describe how family members can best support these relatives. And by family, I use that loosely. It could be the family by definition of that person with schizophrenia. So it might be, a neighbor, fictive kin, somebody from their church community. So whomever they want to bring in who's a support person. So I'm going to use the word family because it's in the EBP, but I want you to know that, and we'll talk about that too, how we can define that. Ways that families can partner with the treatment team to sort of support that individual, and then a potential format, some topics, and a timeline that you can use for those family psychoeducation sessions. So we are going to hit from the ground running, and we're going to give Michelle just a minute to do this, but I'm going to break you out because I want you to get used to this into a group. When you get into your group, I would love for you to identify somebody who's willing to be a facilitator. It doesn't have to be the same person. You might get in different groups each time. So, but I would just, if you can each agree to at one point today, agree to be the facilitator, that would be helpful. We're going to have each participant share a strength and a challenge that they have encountered working with families in treatment, maybe about a minute to a minute and a half a piece. We're going to try to keep these groups to about 5 minutes. So probably I would say like a minute would be even more appropriate. We want to make sure everybody has a chance to say something and to give the why. So the strength, the challenge, and then maybe a little bit of the why. Then we want the group to sort of come together. What are some common themes that you're hearing from everybody? Or insights that you've gotten. And when we reconvene, I would love the facilitators to put what that common theme is in the chat. So you're going to go into a breakout room, the facilitator, you're going to do a strength and a challenge that you have encountered while working with families and talk about a common theme that you've heard. Or if you run out of time, I'll have the facilitator just do that and put that in the chat. So we will see you all in about 5 minutes. All right. Well, if those who could do the activity, if you can just, as a facilitator, just put into the chat for me, what were some of the kind of common themes or insights that your group derived from everybody's contribution? Okay. Getting buy-in through psychoeducation from the family helps follow through, helps family understand. Yeah, absolutely. Thank you, Abby. Common theme, lack of family support hindering the abilities of success of a client. We'll talk about why that might be. Strengths, seeking help, family support, right. Feelings of connectedness, helping family members to see from the client's perspective, creating shared terms that each person, ooh, I love that, the shared language, to build a stronger support. Because families sometimes don't want to use the technical terminology that we use. So I'm a narrative therapist at heart. So I love being able to find language that works for them and feels comfortable for them, giving them agency. Family members who blame the client, the challenge, and struggle to see it from their perspective, reporting that they can't handle the mental health challenges. Yeah. And capacity can be an issue with people who have just not had care in their family system forever or a long time, who just don't have capacity because of multiple demands. So we try to understand that from everybody's side. And how can we create capacity? Some of the challenges, different communication styles. That's right. Family coming in with different agendas. Yep. Theme was families not agreeing with therapeutic strategies. That's true too. And now we have AI and easier access for families to look up things. I remember when I was working on the behavioral health unit, they would oftentimes bring in printouts from the internet, and the providers would get really frustrated. But we talked about that they're trying to advocate and understand and just sitting with them and what's the difference between research-backed interventions and things that you might find on a blog or a TikTok, or so really kind of engaging families and being curious. I was a facilitator. We had themes with strengths of families being engaged and not having the attitude of just fix my family member. Right, very good. Helping families grieve. Oh, very important. Grieving what they thought life would be like for the individual, for their relationship with that individual, for their own point in time. For people who I worked with a couple who had this big retirement plan, and it didn't include sort of providing, care to their adult child who was struggling with a pretty significant mental illness. And so they were having to work through their own grief, as well as the adult child's grief of what they thought life would be like for them as well. Encouraging family to be collaborative. Ooh, you're speaking psychoed. Weakness, lack of recognition of the disability or mental illness, lack of follow through. Yep, and they got a heart. Family dynamics can be very challenging. Psychoed, mental health, showing up is a strength. Ooh, family enmeshment, a little structural thinking there. So sometimes those subsystems in a family can really, and it could be for a variety of reasons, but you might get these coalitions or real significant attachments that form, and then it's hard for people to have change come in, that there isn't a quick fix. Room 22 takeaways. Ooh, I like that. Strengths. Families can help the client apply, learn skills at home, right? Client feels more support, but can lead to more positive outcomes. Absolutely. Challenges. Family members don't always understand the symptoms or the diagnosis and may blame the client, right? And our brains are wired for that. It wants a cause, it wants a reason, and it wants a place to put it. So unfortunately, a lot of times that's back on the symptom bearer if you look at it from an individual reductionistic lens. And that really does happen a lot to families. So they just don't know where to put it. Challenges, parents and schools wanting to fix the kid, lack of communication, strengths, ready, willing to put in work. These are all good. I encourage you all to keep reading them. Family keeping secrets. Oh, that's a big one. All right, for time's sake, I'm going to keep moving, but these are really, really powerful. And you all are the experts in your systems, so I really appreciate it. So one thing is and you probably in your own training or experiences have struggled with this word resistant. We reframe it a lot because resistance can set up a real significant barrier between the work that we're doing and engaging the people that we're trying to help and reach. And so if we look at families as being resistant, then it's difficult for us to think about and strategize around how do we engage them. So we reframe that. Maybe families are being protective. Maybe they're scared. Maybe they're exhausted. And those are all okay feelings when mental illness has come into a family system. It takes a lot of resources, not the person with mental illness, but mental illness itself. And so trying to work with families on even externalizing the mental illness so they can even see the family member beyond that. Um, but very, very important to note that we look for these reframes so that we can work around guilt and shame and anger and blame. So some examples of myths. So there's a lot of myths that can hurt family engagement too. Um, I kind of separated them into two categories. I had them all together and then I was like, it makes more sense separating them. So providers or people who are in the helping role, whether you're a manager, supervisor, peer support specialist, direct patient care provider, case manager, if we go from the mindset that families cause relapse, right, that in and of itself can kind of block the ability to engage families and do effective family psychoeducation. So if that's one of the myths that you believe or biases that you hold, that could be something that's blocking, your ability to move the work forward. If we talk about relapse, we're being negative. So some people were trained in this mindset that if you even talk about relapse, you're going to make it happen. It means you don't believe in the change or the treatment plan. Some families will bring that in too. So that's why I put sometimes family. Some families really believe that they shouldn't talk about it because then that means they don't believe the person can get to where they need to go. But we know that preparing for things, we know this through trauma work, we know this through other evidence-based approaches, that we can set up things that help us to navigate around activators or things that could lead to a relapse. And then we need to know what to do if one happens. So that is really important. What happens if somebody forgets to goes off their medications or starts using drugs or alcohol to manage the symptoms? What happens? Another myth is families are too emotional. We don't want to involve them because it's too complicated. It is. It's family work is some of the hardest work because you're not just dealing with one person, you're dealing with several, and then the interactions among them. So, but we can work with emotions. And if certain emotions are hard for us, and that's an area we can work on as clinicians, but families are not too emotional. If a family's willing to show you emotion, then that means they've been willing to be vulnerable with you, and that's actually a positive thing. Just sometimes we don't know what to do with it. Confidentiality means no family involvement. So some people get really confused about HIPAA and about privacy laws. You need to know those, and there definitely are protections in place for your client. But we also want to understand what those are, what a release of information means, who it needs to be signed with, so that we can educate people on the why we want to be able to talk as a family system and talk to each other. But a lot of people kind of get that part of confidentiality confused, including providers. Some assumptions that families will just interfere with the treatment. Now, it could be that you have a family member who's undiagnosed or undertreated or untreated. So if you're noticing that somebody else is in fact evidencing symptoms that are coming out, then that's an opportunity for us to be able to do some additional referral work or support. Do HIPAA laws change per state? So they're a federal standard, but states might have different mental health laws that might influence the work that you do, which is why I always look for a balance of the state and then the federal. And federal laws and HIPAA's just made a change too. I think they're getting ready to do some additional clarifications, particularly around substance use. So we always want to stay up on those. And then therapy is just for the person with symptoms. And that's an age-old, belief. And so probably 75% of referrals are for individuals, if not more, depending on who you are. But we do know that once we involve families, we can actually move people faster through the change process because we have a greater understanding of what's going on outside of the therapy room or that one individual's self-report. And then there are some myths about families. If we go to therapy, we'll be blamed. So a lot of families are terrified, parents especially, that maybe I did something wrong when I was pregnant, or maybe, I didn't get them involved in treatment soon enough, or I was hesitant to introduce medication. Did I cause this to be worse? And so they won't come in because they're afraid that they're being blamed. Talking about problems will make it worse. I don't ever lie to my clients, but I do tell them, sometimes it gets hard before it gets better. But we have to go through, and I'll give them like a metaphor of a wound, right? If I go to the emergency room, I have a wound, they're going to have to clean it, and it's going to hurt and sting, but that's going to promote the healing that has to happen to get better. And so if you give people a metaphor to understand that process, it can actually help engage them in ways that they'd be afraid to. It could be culture or religion doesn't support therapy, and so that is really important to understand, and to make sure that there's an interpretation that's happening correctly. There's been a couple of times I've had releases signed where I've talked to representatives from their faith community or their cultural community to understand, and the individuals maybe got things a little bit confused. Sometimes they were right, and so we had to figure that out. But I always want to make sure I hear it from the clients themselves, and then I always check in with who they think I need to talk with to better understand. Mental health problems are just a phase. So a lot of people don't understand that certain diagnoses we know are oftentimes throughout the course of an individual's lifespan. It could be things get better or worse, but that education that it's not just a phase or because they're not working hard enough. So we want to make sure we bust that myth too. If we explain the diagnosis, it'll label or limit them. Some people are very scared to put labels down, so they'll use them for billing purposes, but they'll never tell their client. And I've had that happen quite a bit where people have told me, I don't know what my treatment plan is. I don't know what my diagnosis is. And I always like to ask because I want to understand what they understand. They've been participating in therapy prior to me. So it's a myth if we explain it. Now there may be some diagnoses if people are in an episode that it's their capacity to understand it's not the right time. There are some things like dementia where if we explain it, they're hearing it for the first time over and over again. So you want to also, again, be thinking compassionately and timing. Talking about mental illness will make things worse, and then culture and faith should handle this, not therapy. So, so then there may be others. So I want you to break out into the groups again for me, and I want you to just talk about these myths. What are the ones that you've encountered, and how did you handle them? So just to be able to hear from each other, what myths have you encountered, and how did you handle them? Make sure you pick a facilitator, somebody who can help move the conversation around. And this time you won't have to report out in the chat. All right. Well, hopefully you had a good discussion amongst all of you about how these myths have affected you and how you handle them. Because I know if they happen to me on, a frequent basis in the work that I do, I know that you're all fighting the good fight with me. So, thank you so much for the work you're doing to help dispel these myths and really help people to feel safe engaging in the work that we're doing. So, what is family engagement? Engagement is not kind of lecturing, dumping information, correcting families in a way that feels dismissive. We might have to adjust the way that they understand things, but there's a difference between constructive feedback and destructive feedback. Um, and also, engagement is not defending the provider system. So they may have had experiences prior to you that did not go very well. And it's understanding and being wondering and curious about those, not feeling like you have to defend the profession. But one of the things, and I just talked to a client this morning that is so hurtful, is when it appears as if we are doing that and not giving space to their experience of what might have happened in the misdiagnosis or medication management or lack of, appointment structure. And that can really hurt their trust in the system and their ability to engage. So engagement is always listening first. It's validating emotions. Remember, validating emotions doesn't mean we're agreeing, but it means that we are acknowledging that they're having some whatever feelings about this and that those feelings are valid. Offering structure and hope, so a path forward. They do need to feel our confidence. We don't have to be overconfident that we have all the answers, but at least saying, I'd like to meet regularly. And I believe that if we can get together, we can do so much to create, a quality of experience for all of you. And then inviting collaboration over time. So it isn't one and done. It's not just, I just want to have this one conversation with the family, but let's figure out what a cadence would be like to have them regularly come in so we can have touch points on how the plan's working because things change. So, so what is family psychoeducation? It is a structured, recovery-oriented intervention. It provides education, it builds skills, it's designed to reduce stress. And who doesn't want that, right? Including us. So we can learn things along with our families and ways that we can reduce stress. So we're going to talk about that today, improving outcomes for individuals and families. So that's family psychoeducation. It has a strong research base of 40 plus years. Across multidisciplines, and it's recognized by SAMHSA, the APA, WHO, World Health Organization. I mean, it is a highly endorsed approach. So technically, we should all be exercising it, if not components of it, in our work. So who are the ideal populations? Well, it's individuals who are experiencing a first episode of psychosis or FEP. Oftentimes, these are adolescents or young adults, more than likely between the ages of 15 to 30. We think that those are transition years where they begin to sort of do more for themselves outside of their protected family environments. And that's a catalyst for we might see more symptomatology at that point. So a lot of the research kind of coalesces around seeing some initial, warning signs in those early mid-teens and then seeing meeting of criteria from there. It often includes affective and non-active affective psychoses. So it could be something on the schizophrenia spectrum. It could be a bipolar disorder with psychotic features or a brief psychotic disorder. And the goal is family engagement to promote and improve the prognosis, to help reduce those relapse experiences and to improve functional outcomes. And I would say for everybody. So we want individuals to be able to have the best quality of life and to have the most independence as possible, right? Everybody needs a purpose and deserves that. So figuring out how we do that so everybody can have their opportunity for that. Even caregivers, that's the next one. They're an ideal population. Parents, siblings, partners, extended family, other primary supports, people involved in the day-to-day care or decision making. They don't have to be in the same geographic area. Sometimes people who are really involved might live a few states away. So getting creative in the ways that we bring family in virtually to our work. These can be informal caregivers if the youth is older or living independently. And then special considerations or ideal subgroups. So families who are expressing like really high levels of concern, stress, or confusion. Families that are willing to engage in sort of that collaborative treatment experience and are willing to come regularly. There's some that don't need a lot of convincing. They were at the door just waiting for it to be open so they can come in. Parents with limited prior psychiatric education or insight, so they may have never had somebody in their family who's had an episode of psychosis, so they have a lot of learning to do and are trying to understand why, whether it's drug induced, um, whether it's due to other comorbidities. There's a lot of confusion. And then settings where early relapse prevention is a priority. So community mental health centers, early intervention programs, those are really great places for family psychoeducation. Two other areas are this one falls under clinical characteristics that increase, the suitability of family psychoed for patients who are very newly diagnosed or early in the illness course. Now, I will say I have found it very effective for people who have been in the system and receiving care for a long period of time. And it's not just a poor historian or somebody who has a hard time recalling the events of their past because of trauma, but this is somebody who truly maybe has never been explained the symptoms, never even understood what their diagnosis was. So it could be newly diagnosed. It could also be people that have had experiences over time. Families who report high expressed emotion, so a lot of criticism, over-involvement, overreactivity with emotions. Somebody asked what early intervention programs. Trying to remember where we might have gone into that. Let me see if I can go back because I feel bad. Let me go back. Oh, here. Um, where we may have. So there could be things I'm thinking like some evidence-based programming in communities like Clubhouse or maybe some other places where they're really identifying some places where they can do some catch things on the earlier end. If somebody else wants to put some other things in the chat, you can, but that's the one that's coming to mind right now. And I'll think of others when my brain's not thinking about something else. Some broader applications. Okay, these can be for people who have chronic schizophrenia or a schizoaffective disorder, who may be kind of cycling through episodes with a lot more frequency, bipolar disorder with psychotic features, severe depression with psychotic features. I'm also thinking about women who may be postpartum, who may be going through postpartum anxiety, postpartum depression, and may have some psychosis, sometimes due to sleep deprivation, sometimes due to hormonal imbalances and changes that are happening. It's also beneficial in multifamily groups. There's been really good research on multifamily groups as well. So we have people coming together. Um, and I have a website at the bottom for NAMI where they have family support groups. So there are places all across the country where people are able to do that. And then you can have psychoed as a part of that. Peer support groups, particularly for adolescents, can be extremely helpful. And then programs that are very culturally tailored. So if you have a specific religious community, a cultural community, community of people who they have a belief system that's very different from other people around them, and they just need that sense of that connection. Those can really be effective tools. So that's where psychoed can be extraordinarily helpful. So some core principles of family psychoeducation is it's important that the client gets head start. Thank you. Oh, that's right. Couldn't get that into my head. The client gets to define the family. So we talked a little bit about the term family earlier, and it is really important that we're asking who do they consider as family? You know, that word has a very, very personal definition, and we want to be able to understand that and then really respect that client's support network. We're going to talk a little bit about what's called the collaborative alliance. We're going to go more into these on other slides, but this goes back to the idea of not blaming and really forming what we call a strength-based partnership. We're going to go through what's called education and resources. So these can be very unique to different languages, different literacy levels, different ways of processing information and retaining it. We're all different in the way we learn. I can ask some of you to watch a video to learn a skill, and you'll do that. But you others in this room will say, ugh, that's the worst way for me to learn. I need to read it. I need paper. Someone's like, ugh, that's the worst way. I need a conversation with a human being. So, as diverse and different as we all are in the way that we learn, so are our clients. So, being able to have a variety of resources and support so that we can really engage people in a conversation about illness. A lot of guidance and skills training. So it is critical that there are things that they can walk away with knowing and doing and thinking differently. So having some structure to that, teaching them coping skills, stress management skills. One of my favorites is 4x4x4x4 breathing. We have a lot of good evidence that shows that when people are in a stress response state, their ability to think with those higher level concepts is impaired, it's impossible. So I like to even start off my psychoed sessions with just doing some mindfulness or breathing because I don't know what people are carrying when they come into the room, particularly if they're worried about being blamed or they're just exhausted, right? So we'll talk about that. Structured problem solving, so breaking down issues into actionable next steps. And then social emotional support. So, how do we normalize experiences? Um, and how do we reduce that feeling that you're alone in handling this? You can be in a room full of people and feel alone and by yourself. So, how do we reduce that feeling of isolation, not just in geography, but in emotional connection? So going back to that client defines family, respect and collaboration is the key. So family psychoeducation education is not about fixing families, right? It's about equipping them with the knowledge and the skills that they're going to be able to need to manage when things are going well and when things might not be going as well. We also really want to work to see family as knowledgeable partners, even if we have had the 30-year career and we know the DSM-5 TR and we know what the criteria is. I love having families teach me about schizophrenia and what you know and understand, because that helps me to right size the education. Like I'm in a room full today of over 120 experts. You all have expertise. And unfortunately, because we're such a big group, I can't stop and say, tell me what you know about family psychoeducation, and then right size the presentation. But when we get to work with people on that, level of limited engagement, we're able to really get a sense of what they know. And then we can point out that really valuable lived experience. Um, so, being able to honor that either they have had a parent that they've always also helped through mental illness, a friend, themselves, maybe they're a therapist themselves, which is so hard. I find that caregivers who are clinicians are the hardest because they feel like they should know this already. They don't give themselves the privilege of speaking from their lived experience as a family member, and then the lack of knowledge that comes with how to be helpful, because it's a different kind of knowledge and it's a different kind of help when you're doing it because of somebody, you're helping somebody you love versus it's a client. Um, so these are all things that we want to engage and we want to help people to really be able to get the education they need to then be able to partner up with the treatment plan. So ask who they consider to be in their family. Oh, I always love to ask what they've tried. So what has worked in the past and what has not worked? Because the last thing I want to do is repeat an intervention or repeat a way of explaining something that didn't work before. So that's one of my like favorite conversations to have because there may be times where, I might accidentally do something that they just didn't find helpful. Acknowledge their expertise about their day-to-day lives, and then making plans with them, not for them. So, what is this saying? It's not about us without us. That's really important when we're working with families, that they feel like we're doing this work with them. And an example is, you've been living with this for a long time. What has helped during tough periods? So if sometimes I find it's just helpful to have, well, what's an example of how we would ask that question? All right. I work in early intervention, and though we see a lot of concerns that aren't many services. Oh, yeah, the younger children. So we've got, and it is important that we engage children in psychoeducation that's developmentally appropriate, even if they're not the identified patient or client, because children need to understand and know what's happening with their parent or with their grandparent or with their caregiver. But we really, frankly, don't have enough of people trained in child development to know what is the effective ways to best engage them. But that's really important because we know those through ACEs, right? Those first, 5 to 7 years are really formidable for health for that child or for their own ability to recognize if they're starting to develop some of the same symptoms that early intervention and support can increase their quality of life. 100%. I'm so glad you see. This is the smartest group ever. I'm telling you. Okay, second one is collaborative alliance. Again, I love being strength-based. Now, the thing about being strength-based is you have to be authentic and genuine. So that statement I made about all of you, absolutely true. Authentic and genuine. Families can tell if we're just saying something and not really meaning it. It is important that we highlight the positives and the strengths that are true. And I had a supervisor once a while ago that told me if I can't find something positive about the people I'm working with, I shouldn't be working with them. We have to find something that we can believe in, even if it's that they showed up or that they're showing emotion, because the opposite of love isn't hate, it's indifference. So if you have a family member that's just not connecting at all and is completely checked out, that's a lot harder than having somebody who's frustrated. But really trying to be strength-based, building on the things they already do that's helpful, current healthy coping strategies. And I say healthy because sometimes the things we turn to might not always be good for our bodies and our minds and our relationships over the long time, like turning to food or alcohol and drugs or isolation. So some families can be really good at escapism when what they really need to be doing is finding ways to build connection. So how do you build that collaborative alliance? Focus on really good strengths, noticing small wins. So something tiny. Like I had somebody who came in the other day and we've been trying to get her to take her medication regularly. And she came in and she said, well, this week I only took it 4 days. I'm like, 4 days? That's awesome. And she looked at me and she's like, that wasn't what I expected. And I was like, well, what did you expect? She said, I thought you'd get upset with me because I didn't take it all. So I said, I understand what you're working on and what you're working with. 4 days is incredible. What would it take to get you to 5 days? What have you learned about how you were able to do it on those days? Completely change the session around. So, and then reinforcing those adaptive behaviors that they're doing that actually work. So the fact that you're still showing up and asking questions tells me how committed you are. If they're doing research with AI or consulting with ChatGPT, I mean, maybe they're not getting the best advice. Maybe they're getting something useful, but the fact that they're even asking questions and trying is a positive. All right, education and resources. So we really want to, again, expand that knowledge to really build that support and empowerment, which is all about this evidence-based approach. We want families to have clear, practical, and this is important, research-informed information. So anytime we give people information, as the professional, we want to make sure it's backed by credible source. Now, if they share with each other in a support group format, um, you know, we can just let them share, but we always want to make sure what's coming from us, unless we hear things that are really harmful or myths, then obviously we might want to intervene. But I have a Parkinson's support group that I run, and sometimes they'll share things. And I'm like, I always check with your doctor about that. But People find strategies and they want people to know them. But we want to make sure they get information that, again, reduces blame, increases understanding, and then strengthens their ability to support recovery. We want to make sure that that education is shared collaboratively, so we're not giving a lecture or just handing them a book or a pamphlet without explanation. If I'm going to give somebody a pamphlet, I'm going to go through it and say, in this section, here's what you'll find. In this section, here's what you'll find. And so I try to show them the utility of the information or the website. That's another one. If we go to have them go to a website, I'd like to walk through the website with them in session so they can see how to find things. When people are having a hard time, just finding the things they need can be very difficult. So I walk through that with them. Um, Provide accurate, accessible information about the condition. So we always want to make sure we're checking our sources too. We want to connect families as much as possible to community. So building their networks and their supports and their peer resources are excellent partners because as professionals, we can't always be in the space when they most need us. But how can we help them to identify really positive, healthy go-tos for information and support in between those sessions? And then linking education to the real life situations that they're facing. So, right sizing what we're saying. We can kind of talk about most families experience, but I want to know what you're experiencing because then I can build a psychoed curriculum that fits you. And then we absolutely want to invite questions and how can we make this fit for their cultural context? So maybe the words that we're using don't really connect to the words they use in their language. And so how do we bridge that in their primary language? So for an example, you've noticed sleep changes before things escalate. That's actually a common early warning sign. Would it help to review what the research says about stress and relapse so we can plan together? So as they notice, like right before somebody starts to have an episode, these are some of the activating events or the warning signs, and then what can we put into place so that we may not be able to prevent them, but can we minimize their impact? All right, next. Going to that guidance and skills training. So again, the goal is to teach very practical things. We don't just want to, assign fault for symptoms or outcomes like, oh, this is a inheritable mental illness. Chances are this was passed down to you and your family. We think that sometimes what we're doing is removing responsibility from the individual, which it can help, but then they go home and say, well, the interventionist said it's all your fault. You gave this to me. So really want to teach practical skills, problem solving, give really comprehensive information so that they can move forward. Giving it to them instead of like in a critiquing or like if you hear something that may not be accurate, instead of jumping right in there and saying, well, that's not accurate. I don't know where you heard that. Tell me a little bit more about where you heard that. Here's another way I've learned to think about this, and it seems to fit for a lot of people. May I share it with you? Because a lot of our families have gone through a lot before they've gotten to us, so they're prepared. And the moment that resistance it gets a window or a door, it's going to run in, right? So we want to try to avoid language that implies causation or fault, that's going to throw up that resistance hand. Um, and then we talk about framing relapse as a learning opportunity. So we get to learn, okay, that didn't work. Let's try something else. Or, that wasn't quite as bad as it had been before. What did we do different? Let's see if we can do that and then maybe something else. So the example is let's look at a few ways to lower stress during conflicts. This isn't about who's right. One of my favorite communication techniques that I work with couples, if you know Markman's speaker listener technique, and so it's all about paraphrasing. and slowing down the communication, only allowing people to speak in like 2 or 3 sentences, teaching I statements. And it is so effective because it keeps people from thinking about how they want to issue a rebuttal to that or giving a lecture. Sometimes as interventionists, our psychoed is teaching a structure so they can actually hear each other. So it's so fun and it's so effective. So the last, or one of the last, is structured problem solving. And this is where we talk about long-term support and hope. So we recognize that a lot of the serious mental illnesses are going to be something that people will be managing for a long time. And so what are these like stable, sustained supports that we could put in place with them so that they can have some anchor points of hope and thinking about their recovery over time? Really right-sizing expectations for progress, revisiting certain skills, because there's a regression to the mean that happens. I know I'm throwing you back to statistics. I'm sorry for any trauma right there, but we are likely to go back to what we know when stress goes up. So it's practice, practice, practice until we encounter a stressful situation and we can use it, and then our brains will adopt a new process. But we can't just teach a skill once. We revisiting it, putting it in a play, modifying it until it fits. So this is a process, not a cure. The example is this isn't something families master in a few weeks. We keep building skills as things change. Because as soon as you figure it out, something will change. And then there's social and emotional support. So most of the time, by the time we get to work with families, they're exhausted or terrified, right? They have been through it. So we want to really understand that these are normal responses to chronic stress. If you're not exhausted after chronic stress, then you must be doing some really good evidence-based things because it is normal, even if you're doing all the right things, it is normal to feel stress and to be tired. So we want to name things not in an overwhelming or judgmental thing. We want to reframe anger, fear, or urgency as care. So they're frustrated because they care. They're afraid because they care. They feel a sense of urgency to fix this because they care. And then reducing that shame and the defensiveness that can come when we're feeling like we're being judged or criticized or told that what we've been doing is wrong. Like, why haven't you gotten into care sooner? And then any of the brilliance that we have to say won't get heard because people are feeling judged. So some core principles of family psychoeducation, right? We talked a little bit about some of these, but I'm just going to get a repetition so they stick in there. So the client defines the family. We want that collaborative alliance. We want to provide good education and resources that promote support. We want that strong guidance and skills training. We want to have really good structured problem solving skills that to help them to break down things into like, okay, what's the next step? I know where we want to go, but what do I have to do in this moment? And then some social and emotional supports for everybody so they can feel that normalization, sort of like when you're having a really tough day and you talk to that one colleague who's like, yeah, this week is really hard for some reason. And suddenly it just feels better, right? We can't quite explain that, but suddenly it just feels better versus, you have that conversation with somebody like, well, I don't know what you're talking about. This has been a great week. And then you're like, oh, it's just me. So finding spaces where people can normalize that, yeah, this is hard, and then reducing that isolation. So I was going to do a breakout, but we're not, in lieu of that, giving you that break at 2:30. But just for a second, I just want you to think of a scenario where a family that you have supported kind of appeared resistant to care or services, or they were overwhelmed. And how do you think you might approach them differently knowing some of these things? And I'm just giving you a self reflection opportunity because I can think of those cases where I could have done it better. So just giving yourself a thought, what could I just do just a little bit better in the families that I'm serving? So I just challenge you to keep a note of that to the side because I might be coming back to this later. Now I want to move into what's called the vulnerability stress model. So this is a really important part of family psychoeducation. So this is the model that it helps to reduce blame. It explains why these skills are so important. It increases family efficacy. So that sense of we can do this. It supports relapse prevention. It focuses on strengthening the protective factors, and that's really where we're going to spend most of our time. It aligns with family psychoeducation core principles that we just went through, and that it's a shared language that we can all use. What the stress vulnerability stress model is not, it's not neurobiology lecture. It's not a way to blame families for stress, and it's not a claim that stress causes psychosis. So stress does not cause psychosis. There can be certain factors in our environment that if we are predisposed to things, it makes it harder for us to avoid exacerbations of mental illness, but stress itself does not cause it. So the vulnerability stress model believes that symptoms can emerge when stress exceeds one's coping capacity. So symptoms emerge when stress exceeds coping capacity. Think about times in our lives where we have been able to handle more things. Like there was a time where I was juggling, two jobs and I had young kids and I had pets and I had aging parents and why can't I do this one thing right now? Right? Because we change. And that's why we want to understand that sometimes our stress just exceeds our coping capacity. So it's a biopsychosocial framework. So biological, your physical self, psychological, your beliefs, your emotions, your behaviors, and then social framework, your relationships. So individuals have these varying levels of each biological vulnerability to psychiatric disorders. It might be the side effects of the medicines. It might be pre-existing conditions. It might be medical diagnoses that have come because of the medicines. So whether it's weight gain, diabetes, hypertension, trying to think of some other maybe tick movements because of the side effects of medicines. Yes, you can have copies of the slides, Natasha. Happy to share. So this is like really important. This is part of the education is that if we have certain vulnerabilities physically already, it could just make things a little bit more difficult and render less capacity to managing the stress that can exacerbate a mental health crisis. Symptom expression occurs when the environmental stress exceeds that coping, and that treatment works by sort of reducing our vulnerability and lowering stress. So where we can. Now, sometimes we can't control what's happening in the world, but maybe we can watch the news a little less, right? So what are things we can do that maybe moderate or reduce some of the activators that get or make our depression worse, or psychosis worse, or anxiety worse? Um, for some people, it might be limiting interactions with certain individuals. For others, it might be increasing your social network. So we have to figure out what are those things. But we do know, and this goes way back when Zubin and Spring came up with this model, is that protective factors lower risk. Somebody said, I've reduced watching the news tremendously to reduce stressors and anxiety. Right. Absolutely. Lots of flowers and support for that. I think a lot of people have sort of taken that path. So because we can't live in our stress. It is so unhealthy to have high cortisol all the time. We know that, right? It contributes to lots of things, physical breakdown of your body, changing of the way we metabolize food, the way we engage. So lowering our cortisol, taking care of our bodies, and really being able to like shut down some of the things as much as we can that make it worse. And that goes for all of our clients too, right? So we have to practice those things in order for our clients to be able to believe that they work. So what are protective factors? These are characteristics, skills, resources, conditions that reduce the likelihood of negative outcomes. They buffer against the impact of the risk and the stress, right? So in mental health, they can help prevent relapse, improve our coping, and support our recovery. So I would love in the Chatterfall. You just told somebody the same. Thank you, Olivia. The Chatterfall, what are the examples of protective factors that buffer against the impact of risk and stress in your life? What are some protective factors that help you keep from sinking down into a state of depression or elevating your anxiety? Just thinking about things that work for strong family support. Right. And so as a psychoeducational interventionist, we might unpack what that means. What does it look like when the family is giving you the support that you need? So you can tell them, going to church, ooh, having hobbies, learning new things can be very, very helpful. I love art for that reason, for people. Even people who say, oh, I can't paint or draw. It's getting your brain to lock into learning something different that isn't about the stress, that isn't about what is making things harder for you. So if learning something new or just playing with art is a stress reliever, then that can be helpful. Um, exercise, exercise gives us like these natural chemicals that can elevate our mood and make us feel better. Um, I like to go and get punished through spin class a couple of times a week. But I go and it's activities like exercise activities that you can't think about anything else. Because if you do, you might hurt yourself. So whether it's a dance class or cardio boxing or something where you have a program and you have to really be careful and pay attention. Pickleball, whatever people can do. Even walking can be a great resource if that's what people can do. Walking, ooh, big thing. Go outside, touch grass, right? Go breathe the outside air. Get away from the computers. Reading and exercise, 100%. And if you can't read um, off the page, then audiobooks can be another really great one. Just finding strategies to alter a stressful situation. Great. And that's where you can reach out to others. Sometimes somebody who's not in a stress response state might be able to give you perspective um, that's helpful where you wouldn't have been able to get there because you're in fight, flight, freeze, or fawn. Your favorite summer activity, going to the beach looking for shells. Oh, so you might be a mountain person, you might be a beach person. Wherever your safe, calm space is. That's amazing. And we know that the water, the rhythm of the water, if it's in a calm state, can be very good for your nervous system for regulation. The same for the mountains, for rivers, streams, waterfalls, anything that has water and movement. And even the wind and the trees can be very, very helpful for your nervous system. We kind of underestimate what those things do for us. So those are really good things. All right. So these are the discussions we want to have with our clients. What are some things that sort of buffer against stress for you? And for each of the family members, it might be a little different. So, and it can be a challenge if the one thing that helps one person isn't helping another. And so how do we resolve that? And that's another thing that we can step in and have a conversation about. So this model really is big on those protective factors because people have really put themselves through it mentally before they've gotten to see you. So we know we can probably say the most unkind things to ourselves. So we can imagine what our clients and the people we serve are doing. So we want to have a different kind of conversation, and that's what this is about. All right, so this is just an example. Alex is a 21-year-old with schizophrenia who's enrolled in college. The vulnerability is that the genetic risk, so he's got a parent with psychosis, um, with mild neurocognitive symptoms that existed before the onset of a full psychotic episode. So he's got this parent who's had this genetic risk, and then he's having mild neurocognitive symptoms before the full psychotic episode. So he might be seeing like attention differences, like he was having a difficult time getting readings done for his classes, or he wasn't able to learn concepts as quickly as he had in high school, or his working memory, his ability to store information, his short-term memory and recall wasn't working. Executive functioning, his time management skills. He has 5 classes and he was struggling with how to spend time so he can get all of the stuff done. Or even social cognition, like knowing how to engage in conversations or listen to somebody else when they're trying to talk. Self-monitoring that can happen. So we saw some of these neurocognitive symptoms happening before the first psychotic episode. So when I think about college age kids, and for those of you that have served that population, what are some common stresses that college age students have? So this, Alex is carrying these things, but what other stresses are going on around him as a college age student? Acceptance, finals, we're gearing up for that. Oh, lack of money, friends, not knowing what they want to do with their lives, financial bills, right? We don't really understand what a lot of these college students are carrying financially. Academic success. All right, the pressure of academic success could come from themselves, their families. Maybe some of these, college students are, their families are counting on them to graduate and help them financially. Imposter syndrome, right? Balancing social life. Ooh, cognitive. Oof. Well, we know that the brain doesn't fully form until age 25, right? So a lot of the decisions that we made before age 25, I'm sure some of us wish we could take back, but that was all part of our brain sort of working and growing. So we're still what I say growing brain up to 25. I'm going to say plus or minus a couple years. Changing the major. Oh, right. So getting to school and potentially not following what they were most interested in, or not knowing what that was, afraid of disappointment, right? These are all really, see, so all of these things are happening all at the same time for these youth. And if they have this predisposition, then what we talk about is that capacity of being able to cope is impaired, and that just creates a wider opening for schizophrenia and an episode to come forward. All right, so what are some possible outcomes of these stressors when you combine them with a diagnosis of schizophrenia? So all of these stresses that you've named, put in the chat for me, what can happen when these two things come together? Drug use. Yes. Peers finding out about his family. Ooh, romantic relationships might collapse. They might have a schizoaffective response and shame. They might do maladaptive coping, isolating, which is very common. So teaching like RAs or roommates how to manage when they start seeing this, they can drop out of school because they just can't handle suicide, which is a huge risk. Anger outbursts. Right. I call that the Chihuahua response, which is you know that you're small and you know that you're fragile, and so you have to have a very loud bark so people will leave you alone, right? So they just their anger just comes out because they're feeling so fragile, withdrawn, overwhelmed. So what would be examples of protective factors that could sort of reduce the likelihood of these negative outcomes? What are some protective factors that we would want to hopefully learn about for Alex? Right, support. Who are his friends, his family? Does his family acknowledge or understand what's happening? Does he have a positive friend group? Absolutely. So does he have people around him who make him feel wanted, included, seen, heard? Does he have anything else he's doing besides school, hobbies? Is there a counselor who's sort of walking with him through some of this? Or a mentor or a religious connection? Great. Is he making trips home? Can he afford to do that? Is there a challenge with transportation? You know, self-awareness? Right. Very good. Man, you all are just the best. Oh, and you did that even when I didn't give you my clues. So, great job, everybody. All right. Well, as people start to file back in, that will be great. I'm going to go through the next block of slides just a little bit quicker, just because I think I want to move to some other things a little bit more, but these are really important. So, basically, when we're talking about psychoeducation, we're talking about all different types of learning. Talking about the visual imageries. Some people learn best by seeing pictures, watching videos, seeing images of themselves in the materials. So it's really important to have materials that appeal to your clientele. A wide variety of faces and ages are really important. And then also diagrams, maybe some videos, auditory for those that learn best by listening, discussion-based conversations about learning, reading and writing materials, even workbooks can be helpful where people interact with the educational information. And then kinesthetic learning, like role plays, hands-on activities, bringing sensory things to the psychoeducation so they can experience what different textures feel like, what different materials might feel like so they can identify and find what calm and feels like to them. So having those kinesthetic opportunities are really important to that. We also want to think about literacy from the sense that some families who experience low literacy may shy away from materials because they don't want to feel like they don't have knowledge or knowing. So we want all of our materials to be at a literacy level that reflects the people that we're serving and really refrain from using a lot of medical jargon or explaining it. So that would be the other piece of that. So if we're going to use the term, what does that mean? So we try to use plain language as much as possible, simple instructions. AI can be good with that too. So if you ask AI can we break this sentence down into its most concise form? And then AI can do that and sort of help go through some of your materials and see how that works. But we really want people to be able to connect with it. And then we're also very impatient learners. So being able to move through material as quickly as possible. Um, and then having access to translation resources if they're needed. Cultural factors in this, we had talked a little bit before about that. Just want to reinforce that there are different types of learning that happen among different groups. So being able to identify with their core values, their beliefs, any stigma within cultural groups that impacts their family's willingness to engage. Also, storytelling can be a real captivating tool for psychoed for some families that just really resonates with them. So finding out what ways they like to learn and receive information and what types of things stick with them. We want to also make sure we're respecting the family hierarchy and the decision makers. So even though we might be working with adults, understanding who in the family is, like in some collectivist cultures, they make decisions about treatments and medications together. So even though you might be the provider working with that particular person in that appointment, likely they're going to go home and run it past the family. So truly, our client isn't just the person that we're writing the treatment plan for, it's for the people who are around them, supporting them with different levels of support, who are helping to make the decisions on whether or not those things get followed. And then adapting some of the things that we're doing to reflect the cultures that we're serving. So again, making sure there's images in our materials that people resonate with. There's a structure for family psychoeducation that's has some fluidity, but also is pretty common for the evidence-based delivery. So you might have what's called single family sessions, so working with just who that individual's identified as their family. May have multifamily groups, and some it's a both and. Maybe you do a multifamily group once a month and a single family group more frequently. Really depends on the people you're serving, access, capacity, or whether you're doing those hybrid formats, so to telehealth or all in person. So having to build those models around the people you serve, and then frequency can be weekly, bi-weekly, and usually family psychoed is about a 6 to 9 month engagement minimum. So we want to get them through that initial learning phase, the application phase, and then the maintenance. So there's what we call a typical session timeline. There's the early phase, mid phase, later phase, and there's certain things that we're working on. I'm going to go through each of those in the following sets of slides. So the early phase is where you're engaging with each other. It's not a one-time intake. This is ongoing. Some families may take longer to engage. It could be a reflection of what they've been through previously. It could be cultural, it could be biases, it could be access, it could be capacity. They may be overwhelmed or burn out because at this point they've done everything they knew to do, so they're just tired. And that resistance can reflect that fear or exhaustion. Not that they've given up or they're not motivated, they're just exhausted. So in this early phase, we might be normalizing distress. Many families feel this way. Go at their pace. We're not going to rush. We don't want to activate that resistance. So kind of rolling with that and figuring out the pros and cons of learning different things. How do we sort of engage in a way that makes them appreciate the control and the power that they do have in a time where they feel like they have very little? And when we see is when we have that trust, that's when we're able to move forward with the plan. And then really focusing on what the family wants help with now, which may not be what eventually will be what we want for minimizing episodes or improving patient outcomes. But if they don't have a stable place to live, if they don't have access to food, if there's an issue with sudden loss of a family member. I mean, there could be, so what is it that they need the help with now? That will actually help them to be getting into a place where they can receive the information you're trying to give. And I've had lots of experiences with that in my career. So in this early phase around education, it is very interactive. It's not a lecture, so it's having them teach us what they know and understand. Then we share some things that we know and understand, and we're pacing it together. It's very simple. It's very practical. It is repeated because when we're in a heightened stress response state, it's hard to assimilate, and if our working memory isn't one of those things that's particularly strong, we want to keep repeating things so people can eventually get, oh, got the PowerPoint was sent to everybody ahead of the training. Thank you for reminding everybody that. So again, we want to make sure this is interactive. Tie it to real life examples. So if we're giving examples of experiences, resources, protective factors that aren't relevant to our client, that aren't achievable, that aren't practical, affordable, accessible, they're going to shut down. So it is important that if we're going to give examples, we want to make sure that they're meaningful to them. And I usually start by, you know, giving something small and seeing how it resonates. We want to teach families that mental illness is not caused by bad parenting or what you ate when you were pregnant or the amount of stress you carried when you were pregnant. There's a lot of blaming, particularly of moms, that goes on. This is as old as time, back to Freudian days, right? We did mother blaming. And so we have moved past that, or we're trying to, but really removing that responsibility that mental illness isn't caused it by parenting. However, parenting can certainly make things better or worse. So that symptoms will fluctuate. And just as soon as you figure it out, we might have a symptom that might just be a little more challenging. So we want to build into the plan flexibility and room to reevaluate. We know stress can worsen symptoms. So are there any controllable stressors? And that treatment is management, not cure. So really getting those messages in that early phase. We want to build that relationship. We want to validate. We talked about that. Making a very neutral stance can reduce kind of those elevated expressed emotions, and then being consistent. So that's where we take care of ourselves as providers. So when they come to see us, that we are fairly consistent in how we're interacting, our level of patience, our level of compassion, that we really try to create that consistent, safe space. And then engaging with all of the family members and being careful not to over align with one more than another. That's tricky in family work, but that's one of the most important skills that we can grow and develop. And I usually like to tell my families, if it ever feels like I'm, on one person's side more than another, or listening to one person more than another, I need you to let me know because I may not be aware. And sometimes it goes down to just nodding my head. So we were taught basic active listening skills when we went through our training. Sometimes those basic active listening skills can backfire on us if people think that that means agreement. So a simple head nod when you're listening to one member might be sending a signal to another that you're not believing them. So really creating that space where people can let you know if they're feeling like they're not getting enough of space to talk about their part of the experience, or they're feeling like they have that they're being validated and heard. So here's a little vignette. So we have Javier, who's 17 years old, who was recently hospitalized for his first psychotic episode. His mother, Maria, is very anxious and blames herself for his illness. During the first family psychoeducation session, the clinician immediately begins by providing detailed information about schizophrenia, its neurobiology, and prognosis. Maria nods politely, but looks increasingly overwhelmed. Javier sits quietly, avoiding eye contact, and says very little. At the end of the session, the clinician provides handouts and asks the family to read them before the next session. So in the Chatterfall, if you could, for me, put what was done well and then what could have been improved. So what do you think was done well? Because we always want to look for the strengths. And then what could have been improved in this psychoed experience? Done well, psychoeducation, right. Teaching about schizophrenia, provided information about the diagnosis. We don't know exactly what provided, we know it was detailed. So could it have included too much medical jargon? I don't know. But at least there was some information provided. Okay. There wasn't not a lot of interactive elements, right? They were very passive in the recipients of that. So they weren't getting the opportunity to teach the clinician. Not a lot of acknowledgement of the cultural angles as well. Maybe too much information too soon. I agree. right. And then doing those pulse checks with the family. So giving a little bit and then stopping and seeing, how that's landing with them. Right. Providing materials was good, but if we don't really have a good sense of how they're taking things in, it might be too much. And not a lot of validating of emotion, right? Acknowledging the quiet and the potential overwhelm, right? Good job, everybody. This is a good group. So mid-phase is where we really then teach explicit. Keep going with your contributions because they're all very helpful, and each of you could be reading from each other too. These skills are taught explicitly. We also want to practice them and reinforce them. So if it is like a speaker-listener communication skill, or just teaching people how to paraphrase, that people don't know how to do that. So how do we do that? Paraphrasing is just repeating back what you heard. And that helps us as clinicians to know it's diagnostic as well as helps us to know where people are at with their capacity. We might teach things on like emotional regulation. How do you know when you're getting stressed? If your heart rate's elevated? How do you know if your respiration's elevated? And then how do you know how to bring yourself down? And then stress management. So what does that mean? Is it all on you? Who else can help? And then we teach these skills to help reduce the incidence of relapse and lower everybody's stress. And then if there are practical things they need, like access to food, housing, and we can provide that education as well. And it's important to remember that these skills are practiced in the session. You want to give praise, like remember solution, I think solution focused, but strength based. And it's not perfect, it's just progress. And sometimes progress is uneven, but at least moving in a forward direction and from their perception as well. We do problem solving in mid phase. So we really highlight with the families that progress matters. And even if we're practicing a solution that may not end up being the best, at least we're trying things. And that helps. And that success kind of builds confidence so that we can tackle bigger things later. It's kind of like when we have a big project to do, just kind of getting going. And then once you get going, you can gain momentum. Same thing in this. Right? And sometimes we have to go back to the early phase, and that's okay too. That's not failure, that's just making sure we're not missing anything. And all of this is designed to sort of reduce that sense of helplessness and increase their capacity that we can. And it keeps them out of just reactive decision making, which is really helpful. And so this is Layla. She's 14 years old with early onset schizophrenia. She has frequently argues with her parents about medication adherence and school attendance. The family's been attending weekly family psychoeducation sessions for 6 weeks. In this session, the clinician asked the family to brainstorm solutions for her refusal to take her medicine. The clinician offers a solution immediately using reminders and consequences, but hadn't explored the family's ideas or discussed past strategies. Layla becomes visibly frustrated and leaves the room briefly. Again, what was done well? What could have been improved? And I'll let you put that in the chat. So in this scenario, what was done well and what could have been improved? Right? Clinician didn't ask why she didn't take the meds. Is it affordability? Is it timing? Is it side effects? Is it stigma? Is it fear? Is it cultural? No one's no one's talking to her. Right. They're talking above her to the family and not with her, making a lot of assumptions. Right. So when we move to solutions too quickly, we make a lot of assumptions about what they have tried or haven't tried. And they might not tell you that they've tried those things. They're just not going to come back. Barriers to take, right. Are there barriers to taking the meds? Why? Right. So a lot of you are saying we need to back up and understand more about what's going on from Layla's perspective. Good job, everybody. So keep populating that chat. You're doing great. We're going to talk now about later phase. So this is relapse prevention. This is proactive, not reactive care. So we're in a good place. We figured out some things that could potentially help. What do we want to do? What are the activator signs that or stress things that might be coming up in the future that even if it's a good stress, right? A U stress, EU stress, or a hard stress, a distress, like moving, or we know somebody in the family's got a serious illness and will likely pass. How can we be proactive in putting in the supports so that everybody knows the early warning signs, everybody knows personal relapse patterns, and even for families, like if the family member knows when they start dysregulating and not managing, then that can affect the other individual with schizophrenia. And we want to have very clear action plans. So if a family member needs to tap out because they are going through a work crisis or a health crisis or their own stress, who can tap in? Who else can come fill in that role? So early intervention can reduce severity and duration, but we want to have this written down so everybody has access to it. And really making sure people know relapse is not failure, right? We want to just learn through that process, and that's how we get better. Sometimes we need to sort of not hear what we want to hear or experience in order to know what we do want or how we can change our ways to get there. That later phase is all about building independence and confidence, and that's functional independence, not absence of symptoms, but just how can somebody function to the very best of their ability and be as independent as possible. And sometimes then families, when they get to that place where the individual's doing well, they don't want to let go. But we still have a developing person, like who's still going to be able to meet milestones in life. And so being able to let go, but put supports in place. Um, to not be afraid of setbacks, but be prepared for setbacks if they should happen. And that overprotection can be the shade that keeps growth from happening. So how do we do that? And that overprotection may be something the family members may need to explore in their own therapy, is to understand that because it's very hard letting go, especially when we get people to a place where they're doing well. So confidence grows from those small successes, and it's our job is to help point those out. And we don't want to end family psychoeducation too abruptly, so that needs to be planned out as well because sometimes we become part of that stabilizing structure. And so if we're like, well, your 6 sessions are up, and we walk out of the equation without a plan, without other resources and supports that can be put in place, that can also be pretty injurious to a family, especially one that has very limited supports. So we also have to be careful on our exit plan too. This is Ahmed, who's 20 years old. He has been stable for 6 months on medicine and he's gone back to college. His family and the clinician are reviewing his relapse prevention strategies. During the session, the clinician focuses almost entirely on potential warning signs and emphasizes how careful Ahmed must be to avoid relapse. The family leaves the session looking worried, and Ahmed reports feeling micromanaged and anxious. There's no discussion of strengths, independence, or recovery goals that occur. So, again, what was done well? What could have been improved? Please go ahead and put your thoughts in the chat. I would just, point out just for time's sake that, it's good that they're having this session. So to kind of help do that relapse prevention strategy, but it sounds like it wasn't engaging Ahmed, wasn't engaging the family, and it got everybody elevated looking backwards versus forwards. It wasn't looking at the vulnerability stress, wasn't looking at protective factors, um, and really labeling Ahmed as his illness versus his potential. So always discuss strengths, right? So we're going to do a little matching exercise here. This one is going to be a little bit longer for time. So we're going to give you a little more time in the breakout group to do this. I want you to identify a facilitator. If you haven't been a facilitator yet, I'd love for you to try. All that does is keep the group moving. You have a family profile that's been emailed to you. Does everybody receive that? Great. Okay. So there's a set of discussion questions that go with that family profile. If the facilitator could just take notes, that'd be great. And then what I'd love for the facilitator to do is to just offer responses in the chat, and I'll cue you on that. You don't have to put it all in the chat. I'll cue you on some things. So we're going to give you I'm going to do a little less time. I'm sorry. Can we modify the time a little bit, Michelle? Would that mess you up? Okay, let's do about 8 minutes. Just get through as much as you can. But let's do about 8 minutes with this activity. Welcome back. Hopefully you got a little start to the worksheet. And honestly, the worksheet itself can be a really useful tool for just organizing your thoughts about clients. So even if you didn't get the whole thing applied to our family, to the Lopez family, then at least you can be thinking about when you are meeting a family for the first time in the early phase, what are the main challenges they're facing? How are they reacting? It just allows us as clinicians to sort of slow down a little bit and make sure we're doing all of the evidence-based components of this particular approach. Is there anything anybody wanted to share about their experience or any realizations with the Lopez family? You can feel free to raise your hand and we'll unmute you. Okay. We've got somebody there, Michelle Boyd, Mr. Boyd, or Miss Boyd.
Yes.
Yes.
So we talked about a couple of things that the family wants to support but don't know how.
Right.
Not having a good understanding of the medication and maybe discussing with them medication in addition to also taking in consideration their spiritual belief systems.
Very good.
And then we also talked about the language barrier,
Mm,
because Sophia is the only one, it states Sophia is the only one who translates during healthcare sessions. And with that being said, if she's the only one translating, she may not be translating the information correctly or all the needed information so that the parents have a good understanding of what's going on. So we talked about having an outside interpreter that
right.
can be in those sessions so that as a way to ensure that the information is being translated both ways
Yeah.
correctly and effectively.
Very good. Great job. Great job capturing all of those details and the stress of for Sophia that that's her role in the family and not being able to do that. And that's hard, but we need to lift that from people so they have capacity to manage their health. We have Alexandra. We can do
Um,
another one.
yeah, we got kind of cut off in the end of our little breakout, but uh, one of our members was making a good point at the end there that we were talking about bringing in the spiritual piece and relying on the family's spiritual connections if they attend a church and kind of who to include in their treatment team to address the needs,
Yeah,
especially if they are attending a church and including their pastor. And she was saying at the end there that it's important to consider and make sure that everybody in that treatment team understands what their roles are in that situation, because we were talking about the difference between the support that a pastor can provide and like clinical counseling and that kind of stuff, but including all those pieces.
perfect. Somewhat like why it's sometimes good to talk to each of the potential participants ahead of time so you get a good understanding. Is this somebody who can be helpful? Is this somebody who has capacity to be helpful? Is this somebody who would understand what they're being asked and can do that and that fits within their role, their abilities, their scope, and that they're not going outside of that or feel like they have to go outside of that? So I love having those pre-meeting discussions just so we can kind of level set as providers and collaborators. So that's a really good point. All right. Is it Hallie or Haley? I'm sorry. She's trying there. She
Oh,
goes,
there we go. Sorry, I couldn't unmute myself. I apologize.
no problem.
It's Haley. You had it. That's
Haley.
perfect.
Good, good.
With our group, we pretty much kind of like all unanimously agree that like the main challenge that like the family's facing is definitely like the language.
Yeah.
With her being the only with her being the only person able to kind of like tell her family like what's going on with the medical portion, and her being that symptomatic, you never kind of know like what's going on.
Hmm.
um Her mom and dad, with the reactions, they seem like, they want to help her. They
Hmm.
have, love and good kind of reactions to her, but the other, extended family,
Yeah.
maybe isn't reacting in the best interest of maybe being in the culture that we are now, but maybe they're acting in the best interest of, of their cultural background. So that one's kind of
Right.
a tricky one.
It is.
And then we all just kind of, touch base on, handouts, would, should, be in Spanish, and, making sure that, you are using the correct language that the family is using. We kind of spoke a little bit about like having different clients that we, all thought, maybe spoke Arabic, but we didn't know that there's many forms
Yeah.
of Arabic, and hitting those discrepancies as well, making sure that you're using the correct language terminology from exactly what's going on. And that was just kind of like what we all talked about. We didn't have a lot of time, but
Oh,
that
you're
was
did.
that was the extent of it.
But this is a lot to unpack, and I appreciate how much you got done in 8 minutes. That's impressive. So wanting more time for this just tells me you're called to the right thing. You guys did a great job. So, but and to know that there's different dialects, and so even if we do get a translator, they may or may not speak the dialect that the family speaks, and so it is very difficult to always land it smoothly, but we do our very best to help people and support them in speaking in the language because that they want to speak in and learn in. It just results in a better outcome. So, great job. All right, so big picture takeaways is that family psychoeducation is a phased approach. It's flexible, it's collaborative. That early phase is all about giving some trust and safety and understanding. That middle phase is where you teach the skills and to have the problem solving. And then that later phase is maintenance and confidence building and efficacy building. And you move from teacher to coach to consultant in those phases. So early phase, you're teacher, mid phase, you're more of a coach. And then in the final later phase, you're a consultant. So when we're structuring these experiences, we want to include family members as early as possible. We want to recognize their expertise, want to collaborate with them in problem solving. There's different structure tools like a 6-step model, and we can talk about that. And then we want to respect their boundaries. So just because we have a partnership doesn't mean that we just accept and share information freely. We still want to acknowledge and honor that the client who might be the symptom bearer at that point in care still has rights and privileges. So, for us to engage in emails and phone calls and things behind the scenes without fully incorporating or discussing with the client that we're actually impairing the progress of a good outcome. Now, if there is a huge crisis event, I mean, you have to use your best clinical judgment on that. But this is like an ongoing behavior. Like, okay, we talked during that crisis phase, but we really need to be talking together from this point forward. And we really want to balance that autonomy with family involvement. We want confidentiality without exclusion. So HIPAA doesn't mean silence. I was once working in integrated care, and I had um, a person coming in, and we were just going in to do a screener, and they said, I can't talk to you because of HIPAA. So our patients need to also understand what that means and what privacy means. And it's very important that we walk through those conversations, but that we can, providers can read, and I always tell family members this too. If the loved one won't sign the release, there's nothing stopping the family member from reaching out to the provider and sharing information. They just can't share back. So if you're seeing that your loved one is not taking their medicines or is having some elevated symptoms, you can reach out as the family member to the therapist to let them know. Sometimes we have to empower and educate families on when is it okay to kind of break the glass and when is it important to go into the session with them. Sometimes the person won't let the family member go, but there's important information that needs to be shared. So we sort of work with that. The purpose of that initial conversation is to really, the whole point of that first session is to establish trust. So everything you're doing in that initial encounter is trust building. I start my session, the initial sessions off with, this is an opportunity for us to get to know each other. If by the end of this hour or how much time we have together, you don't feel like this is going to be a good fit, please tell me. And I will do my best to find you somebody that would be a better fit, because our job is to get you the very best care. That sometimes gives what welcomes agency into the room and sort of takes the edge off. And if there's any, concerns that they're not going to have any rights and voice right away, they hear that present. So it sets the foundation for a good engagement, even if it's just that 1 hour. And it shows the family you're going to be collaborative. In this first hour, we're going to explain that role of stress and vulnerability and those protective factors, because those are just seeds of hope. So it's important that we talk about what this process of family psychoed is, how we're going to move, to this place where they won't need us anymore, and what that involves as far as planning and prevention and resources. But the whole point is we want to instill hope in a space where people just haven't heard that as an option to them. So some tips for different conversations, for example, in preparation phase, you want to review their history, find out what they want to accomplish. Those are important things. We want to be strength-based. We want to highlight the things that are already doing well, avoiding blame. And when I say actionable support is, I would say if I was doing a videotape, what would I see happening? Like, what does listening look like in your family? How can you know or tell somebody's listening? What does support look like in your family? What do boundaries? If you could show me a boundary interaction, what would be happening? It's really important we break those down into actionable steps, because our own understanding of what that is can be very different than the families we're working with. Rapport and trust, um, introducing self and our roles very clearly, validating their emotions. And that's one thing we didn't talk a lot about is our roles. Like there's a lot of confusion. Like we get how we're different, but for families, like I don't prescribe medicine with my license, but there's lots of times my clients will bring in their bag of meds. And so I appreciate that because I like knowing um, for monitoring of side effects, because there are certain things that I can help with. But for the most part, being able to then say, okay, this is a psychoed moment where I can explain who I am, what I do. But that is a really good thing to always bring your meds to your provider. Collaborative framing, and then some key concepts in that. So we want to talk early on just a little bit about psychosis in that initial session. Really avoiding using a lot of medical terms, but really giving some understanding of what it is, learning how they are observing it, seeing it, and explaining it, and then adding in some of our own education. and that we know stress can make things worse, and understanding what kind of stressors they've been through. And these are just some more things that we can do for those initial conversations. Again, asking what they know or believe, validating common emotions, really getting a good script of what next steps could look like, immediate risks, and understanding those belief systems. And these are just examples of opening statements that you can give and things that we certainly don't want to overpromise outcomes. And that's the great part about psychoed is that it's not about you have to deliver something. We're being very client patient centered and creating a curriculum that's going to make sense to them. But we certainly can't promise outcomes like cures and things that are just not either possible or within our purview. And these are just some possible responses, so of what not to say and what we could say. So for example, what not to say, because of confidentiality, we can't really talk to you, right? So what you could say is there's some things I can't share about your relative's permission, and I really want to hear your perspective and make sure you have helpful information without their permission. So you might have people call your office and say, I know you're treating my son, my daughter, my parent, and they're adults. And so I can't confirm nor deny that they're seen here for services, but if they are being seen here, the only way that we could speak with you would be if they signed a release of information. So please talk to your family member about that and your interest in helping them, because that would be the pathway to talk. So I don't just not acknowledge, but I try to do a little education on the phone too, so that if indeed they are a client of ours, this family member knows the process. What not to say, we need to hear from your son directly. He's the client. That can really put up walls for family if we're trying to like cut them off mid-sentence or have them sort of not feel like they're important to the conversation. But instead, your son is the primary decision maker here, and your insights are incredibly helpful in understanding what's been happening. So reminding them, even though I want to hear what you have to say, ultimately, he's going to be the one to decide what are the next steps, unless it's dictated by state law otherwise. And there's just some other examples. I'm not going to go through all of them, but they are in your PowerPoint. So different ways of saying things. I'm a big fan of like examples. So you're going to find in this deck, I stacked it with examples because that's how I make things come to life with my brain. So hopefully that'll help you as well. So this is that 6-step model I was talking to you about earlier. So how do we move through this collaborative 6-step method? And psychoeducation has found that the first thing we want to do when we're working with a new client, right, is we really want to understand and identify the problem. Then we want to set a concrete goal. We want to generate as many solutions as possible. Evaluate the pros and cons of each, so a little motivational interviewing in there, and then choose a solution that the family, everybody can support, and make a plan. Then we want to review the outcome to see if it's as good as we thought it was, or if we weren't able to do it, so we can make those adjustments. I love explaining the process up front, so again, people understand sometimes we have to take a step backwards to take 3 steps forward. And that can be part of the process. It's a very concrete, non-blaming structure. So first step is identifying the problem. And really, we want one specific manageable problem. We try to tackle too much. We're not going to learn. The idea is getting a framework for problem solving that we can apply other things to. So it's not that we're going to fix all of it, but we're going to see what do all these things have in common, and could we come up with working on one that strategy can be used for the others. So in this example, Sam is missing morning medication doses 3 times a week. So we want to teach families to ask what exactly happened, how often, when did this start? These are the things we want them to not only ask the loved one, but we want to ask of them as well, so we can get a real well-rounded understanding what exactly the issue is. Maybe for Sam, um, he's up really late 3 nights a week because of work. So he sleeps in through his medication morning time. So we just want to understand what, from his perspective, is the barrier versus he just doesn't want to do it, right? He's just being difficult. The second is to find a concrete goal. So oftentimes, if goals are no more stress. Oh, I wish that that would be great. But if goals are too vague, we're not going to be able to see the progress that the family needs to see to get that forward momentum. So too big of a goal could be, that Sam has to take his medication all the time on time. But can we move him from like 3 times a week where he's not taking it to maybe he just misses it once a week? Or can we get him to like 6 days a week? Get some momentum, get him in that new habit that's being formed. If the medication is life-threatening and he needs it, then that's a different kind of intervention. But we're trying to change and reshape a pattern of behavior. Doing it little by little can be very esteem building. We want to make sure that the goal isn't just set by one person, like the parents dictating the goal. So it needs to be one that everybody has stake in the game in. So everybody's buying into the outcome being successful. All right. The third is the brainstorming. This is kind of a fun part. It's like, okay, we know what the problem is. We know what we want to get to. How do we get there? So this is the creative part. Let people fly. Get a whiteboard up. Let them write ideas. Or everybody has a piece of paper. All the ideas you can think of are ways that we can get there. It can be a lot of relief for families that everybody is getting a chance to brain dump, and then everybody sees what they put down. And you know what? Sometimes the same thing's on everybody's list, and that's pretty awesome when that happens, because maybe that's then the right thing that needs to happen. So as an interventionist, we just step back and let them. Now, we might need to help a little bit if they're struggling just to get going, but we want to really just teach the families that any idea is allowed, right? In this phase of it, quantity over quality. They don't have to come up with the perfect one. Just put it all down. Even things that seem like outside the box, like we train the dog to bark at 8 a.m. I mean, let it be wild and see what happens. No criticism, no judgment. Everybody's ideas have value and merit, even the silly ones, because sometimes the silly ones can work. So if we practice brainstorming just for a second in the chatterfall, if a family member identifies the problem as my relative keeps missing appointments, right? Pretend that you're a family member and the provider just asked you, what are some possible solutions to your loved one's missing of appointments? Let's pretend we're a family. In the chat, just throw out there even things that are kind of wild that might help alleviate this problem. Get my chat back up. Okay. Schedule a family meeting, buy the client a car, get an ROI, get a job. Okay. We'll assume we have the ROI, right? Schedule times, appointment reminders. Ooh, use of a calendar, right? Appointment reminders. Okay, so and that might come in different forms. Ooh, find out why. Maybe we keep scheduling this person for 8 a.m. appointments and they're not an 8 a.m. appointment person, right? So it could be the timing, it could be transportation. Ooh, a reward. So something that like cost outcome, right? Like maybe a milkshake is a small price to pay for somebody who keeps having dysregulated mental health. Do telehealth if possible. Right, good. All of this brainstorming. And that's what we want to do in the moment and just get all the create because they're going to give you lots of insight then into what they tried, what they haven't tried, and what's possible outside the box for them. So very, very good. So we want to evaluate, and then we take all of these solutions and we pro and con them. So maybe we can't train the dog to bark at 8 a.m. All right, maybe that's not possible. Or maybe we can't buy a car. Um, but what's practical? What can we do? And you start narrowing it down. Again, just teaching them how to like honor all the voices and then how to kind of rest on something that feels that we don't want right versus wrong, that this is just about what seems realistic and practical. And maybe come down to a few ideas and then praising them for the effort they put in. Which of these ideas will lower stress the most? If somebody's having to miss work a lot, maybe it could be a telehealth option or finding a provider who does evening appointments. So really asking what might make this easier or harder. We don't want fear to drive decisions. We don't want it to get into a space of blame or overcomplicating things. This just needs to be kind of a fun, unstructured, somewhat structured activity where we get to some practical ideas. And then we choose a solution and we make a plan. So we put together these, sometimes I'll draw a staircase, like what's step one, step two, and make it time limited. So we're going to practice it this week. So for this week, we're going to try that solution. And if that one doesn't work, then next week we'll try this other one. And let's say Sam's going to set his alarm at 8 a.m. And maybe he's going to pair that with taking his pills at the same time, and he's got a pill organizer. So whatever comes out of that. And then after that week, we're going to review and adjust. So maybe the solution wasn't bad, it just needed to be tweaked a little bit. All right. Or maybe they had a life event come up, which always happens, right? And it just wasn't a good week to do a new project, but we're going to try it again this week. So we're going to move forward. So that breakout. We want to teach families how to take breaks. Oh, the big one is naming emotions. So a lot of our families have very limited emotional vocabulary. And I don't know if you've ever tried this. It's one of my favorite activities. But you know the game Jenga with the little bricks? So you can get that game for like about $10. And then I take a Sharpie marker and on the bottom, divide the bricks in half. And for half of them, I'll put kind of like emotions people like to feel, like happy, joyful, excited. And then the other half will be emotions that are a little bit more difficult to feel, like sad, guilty, disappointed. And we put the Jenga game together, and then I'll have them pick a brick. They have to follow the rules. They pick a brick, and then they say the last time they felt that emotion. Now, if I'm the only one with them, I'll play it too. I just try to not give examples that are out of the appropriate role, but it's better if the family's there and I just sort of facilitate it. My families love this activity and they end up going pretty deep and you can make it a topic related to the psychoed. You could just do an open-ended one, but it helps them expand their emotional continuum. It also helps them kind of de-escalate a little bit. And if they do, then you can teach de-escalation strategies right there in the moment to find out what works. And that allows us to normalize emotions and feeling. So strong emotions are expected in certain situations. So stress, vulnerability, and relapse. So stress, especially relationship, interpersonal stress, can increase symptom severity and risk of relapse. So we want to really talk with families about how they handle conflict, rapid changes in mood that can happen, that can be unpredictable for people, a lot of criticism in environments, A lot of intense emotional reactions or unpredictable routines can be really difficult for people, especially who are navigating through psychosis. So these are things we want to try to focus and provide some education around because we know lower stress can result in fewer flare-ups. So the delicate balance is we don't want the messaging to be the family is the blame, um, but they have an influence, right? So stress happens in all households. We want to normalize that too. So that messaging needs to be very clear and careful. And these are just some things that families sometimes do under stress, but we want to make sure they keep it brief, calm, and focus on one thing at a time. Try not to layer your questions, layer your commands, one thing at a time. Especially for people who might have neurodivergent needs. So we also want to acknowledge that on top of everything else. We want to validate. You can do that without agreement. So really teaching like how do we acknowledge that somebody's having some big feelings without endorsing the behavior that might be going with them, right? Like even though they're throwing things, we can say, I hear how scared you are, right? You're not endorsing that they're throwing things, you're just trying to connect with them around the feeling that might be resulting in the action, right? What we don't validate are delusions, harmful behavior, and unsafe choices. We want to coach our families, teach them how to have questions that they can use at their disposal to ask their family members, teach them how to share observations when they come in and talk with us. We want to focus on behaviors, not judgments. And then in our role, really ask for clarity. And then let them also comment on their behaviors that they've noticed about themselves or their loved ones. So they come prepared for psychoed with questions. Those are my favorites. When there's disagreement, we want to normalize conflict. We want to teach people to stay calm and go back to the goal, the shared goal. Sometimes families will come in what we call the flavor of the week. So I encourage you to go back to grad school or undergrad or your training, and you're kind of listening for the theme. What's the qualitative theme in all these things? And see if that's something we can pull together as a goal. And really avoiding power struggles. Sometimes, like people are giving you examples of something they want changed just from different contexts. So we want to see what do all these things have in common. What families oftentimes remember from family psychoeducation, and this is through research, is they feel heard and understood. They appreciate clear information about the illness, practical strategies for coping, concrete action steps. They appreciate how much you all deliver hope and recovery in that orientation. They appreciate the collaboration that you invite them into. And they appreciate support from other families, so that peer-to-peer component is also really helpful. Here's some sample topics that we have seen been used in psychoed. So if you were to come up with a curriculum and even a multifamily group curriculum, these are some topics that could be really helpful. So you can do like part psychoed, part breakout, and they talk about the topics. So I provided this in a list in the PowerPoint for you. Just an example. You probably can come up with even more. So as we end, and we have 10 minutes left, is I just want you to think about if you can put in the chat or fall, in the chat, one activity, one thing that you think you're going to try to do differently as a result of this training. What do you think you'd like to try and do differently? So this is a manifestation exercise. We're manifesting this to happen, right? So what would you like to try to do differently as a practitioner of family psychoeducation? And as an administrator, maybe how would you like to support it more in your environment? The block exercise. Oh yeah, I love the Jenga. Sometimes when I do live trainings, I'll bring it. It's a lot of fun. Use the visuals more. Good. Block. I love the block. I love it too. Pros and cons, right? Getting all the solutions on the table and let's like pro and con them. Watching for body language, right? You're nodding and how that could appear to others. Right. Oh, very good. Highlighting strength. Oh, strengths are good. Right. People oftentimes come to us so beat up by life. Family strengths, right? Pros and cons. Good. You guys are manifesting great things. Right. Inquiring of what interventions has worked before. I love it. Not layering your question, slowing down, right? Oh, the worksheet. Yeah, I didn't think about it when I developed that for this training, but that actually is a really good tool to use. Right. Sometimes when we get rushed, we want to push our own agenda, and that can really block progress. More therapeutic listening. Making sure Dawn said, making sure all family members are involved. Very important. Because sometimes because of geographic proximity or work schedules or family dynamics, we might not have everybody in the room that we need to. And how can we flex to that so we make sure of that? What games they like to play and incorporate them into the session. Oh, I love that. I love that. Or coloring, if that's something they like to do. Very good. Well, we have just 7 minutes left, and if you have any questions, and keep populating the chat, feel free to raise your hand. You can unmute, and then also, um, I wanted to put up that NAMI has some family support groups. If you haven't already been exposed to them or know about them, they're linked on the slide. So you can find a NAMI family support group closer to you, or, if not, you can look at the Virginia affiliate to see about starting one. So how can we create these environments where families can support in a strength-based way? How to work together and lean in to learn together. So I just wanted to provide that. If you have other resources for family psychoeducation, please utilize them. But there's the question. So anybody, see if there's any hands raised. It's okay if there isn't. All right. Well, we want to make sure that while some of you might be thinking that there's a survey to complete to receive your CEUs, and that is linked by Michelle in the chat. And really do appreciate your feedback, not only because I really appreciate hearing it to develop, but also myself as a speaker, but also I think it helps the curriculum. So, oh, Diane, yes, please.
Quick question.
Yeah.
I'm just curious because I had this on my LPC exam and I didn't know if it
Ooh.
was right or wrong, but I'm curious. It was a family oriented question, and the question was if you're in session with your family and you tell them to talk amongst themselves, you wanted to kind of observe the family dynamic
Mm-hmm.
and you ask a question. And then you tell them to kind of talk amongst themselves, but they direct the conversation to the therapist.
Mm-hmm.
Would you ignore them and let them try to figure it out? What your question? Would you kind of reiterate to them, what you recommended? How would you handle that situation? Would you speak to maybe the person, the person, I won't say in charge, but maybe the head family member or whatever to,
Right.
you know what I mean? So how would you handle that if you had an
Right.
assignment in this session? Does that
So
make
let me make
Yeah.
sure I'm understanding it. So the assignment is to get them to have a conversation amongst themselves so I can sort of observe some of the dynamics and
Yeah,
things that are going on. But once they start the activity, they're looking at me and talking to me instead of to each other.
correct. Yeah.
Okay. It happens all the time in my work. So the way I would do it, I may fail the LPC exam if that's the case, but I just remind them that I would love for them to be able to talk to each other. So I very gently just redirect them. Diane, you're having a lot of really important things to say. I wonder if you can sort of share that with your family directly. So I kind of gently try to guide them back to each other. Sometimes I can do it like non-verbally, like I'll just move my hand
Mm,
and they'll look at each other and they get used to me, so they'll know what that means. But I do in the beginning try to help them realize that I love hearing what they have to say, but what I'm really hoping is to see how they are sharing that with each other. Um, so that's the way I handled it. Would I have failed that question, Diane?
no, I don't know. So, yeah, so I don't know. So I was just curious since this
Yeah,
was the family,
yeah.
session. I just
That
wanted to,
that's
yeah.
That's how I would do it. And I have done that. Like I've done some observational stuff. I'll watch conflict to a certain degree unless it gets unsafe in the room. Sometimes as an interventionist, I want to sort of see what they're trying and where they're getting stuck. So it is really helpful. We call those enactments. So it
Mm,
is really, really helpful to have enactments as long as, like I said, it's not creating an unsafe environment.
okay.
So
I
great
appreciate that.
question. No, I
Thank you.
appreciate you.
Okay.
Well, I want to honor that the time is at close, so you have 3 minutes left in your day. 2 minutes, sorry. Thank you so much for participating. I really have appreciated this. And thank you, Michelle, for doing a fabulous job at the breakouts.